Hey, Susan, I just wanted to check my audio and video.
They are both great. Is mine okay?
Yep, sounds great.
That's great.
Is Robin here? Give her another minute here. Hey, good morning. Looks like we have everyone here. I'll call to order the Green Mountain Care Board's hearing of April 29th, 2024. We have a busy schedule today, and we'll probably have to carry over some of the work to Wednesday. Today's substantive presentations will have an advocacy group presentation on the AHEAD model from a group of healthcare policy advocates here in Vermont. We have a potential vote notice for the 2025 All-Payer Model Extension Agreement. And then we have our monthly AHEAD Global Budget Payment Design Update, which should start around 10:45, maybe a little bit earlier. With that, I'll turn it to Susan Barrett for our Executive Director's report.
Thank you, Mr. Chair. Can you hear me okay?
Yes.
Okay, great. So in regard, you mentioned the update to our schedule. It's likely we'll add this AHEAD global budget conversation to the agenda on Wednesday, as we'll need more time, I'm sure, to discuss these important issues. In regard to public comments, we have a new public comment period posted that I wanted to alert the board and the public to, and that is regarding the Vermont's all-payer claims database, VCures, and we are making revisions that we have proposed revisions to the reporting manual. So please, if you are interested, we'd love to hear from you, from providers, from payers, etc. Please check that out. It is located on our website for public comments, and we'd like to hear those comments by May 31st, 2024. We also have two ongoing public comment periods. The first is regarding the community engagement work we're doing on hospital sustainability per Act 167. We're continuing that work. We'll be back out in the communities later this summer, so stay tuned for those updates. We'll announce them when those dates have been confirmed. And then we are accepting ongoing public comment for Vermont, a next Vermont all-payer model, the AHEAD model at this point, and any comments received for that potential model and that work are shared with our colleagues at the Agency of Human Services. And with that, I will turn it back to you, Mr. Chair.
Thank you. We had last week off for school vacation for folks with kids, and their last meeting was April 17th. There are minutes from April 17th. I move to approve the minutes.
Second.
All in favor of approval of the minutes from April 17th, say aye.
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 Aye. And the minutes are unanimously approved. Our first presentation today is from a distinguished group of, I'll call them policy experts and folks that have had various clinical experience here in Vermont for many, many decades and leadership positions in the Vermont healthcare community. Patrick Flood, the former Deputy Secretary of AHS, Dr. Marvin Malik, who's a primary care physician, Dr. Deb Richter, who's also a primary care physician, Kelsey Stabseth, who's the Executive Director for Northeast Kingdom Human Services, and Deb's now the critical care nurse at UVM, and she is also the president of the Vermont Federation of Nurses and Health Professionals. They have asked to provide their views and information relating to healthcare reform here in Vermont and the AHEAD model. And I wanted to thank you all for being here and being willing to do so. One of the things that has shocked me in my time here at the board is how much people volunteer their time to have input and participate with us. And it's really, it says a lot about the state that you all take the time on your own to put this together and to come help educate us and help us think about the issues before us. So thank you for doing so, and I'll turn it to you all, and you can introduce yourselves again if you'd like, if I missed anything important. But otherwise, I'll turn it to you and thank you. Patrick, it looks like you're speaking, but you're not coming through.
Okay, thank you very much, Chairman. Can everyone hear me? I have difficulties. I'm having trouble being heard. I tried my camera. Can you
Patrick, it sounds like it might be like almost like a tape delay or something. It's coming through, but it looked like you were speaking before there was sound. That sounds better. Patrick, do you want to try again? And I think if you keep your video off, it might work better.
Okay, I'm going to leave my video off and see if you can you hear me at all now?
Yes.
Okay, I'll talk slowly, and my connection is oftentimes not good. First, I want to thank the board for the opportunity to speak this morning on this really important issue of the AHEAD model. I would like to spend a minute introducing myself to the board. I began my career as a nurse, and I worked in a wide variety of healthcare settings, including, in fact, at the emergency room at Central Vermont Hospital. I worked in state government for 29 years. I ran the division that regulated nursing homes. I worked with the rate setting division. I was the commissioner of the Department of Disabilities, Aging, and Independent Living. For 7 years, I negotiated the very successful Choices for Care waiver with CMS that has saved the state tens of millions of dollars over the past decade. I was the Deputy Secretary of AHS for 4 years, working on a wide variety of issues, including corrections, homelessness, and issues related to trauma. And after Tropical Storm Irene, Governor Shumlin asked me to be the Commissioner of Mental Health to rebuild the mental health system after the state hospital was closed. After I left state government in 2013, I ran one of the state's largest FQHCs in the Northeast Kingdom for 3 years. During that time, I also served on the board of the local hospital, the NVRH. And during that period, I was also the chair of the ACO for the FQHCs. It was called CHAC, and participated in the discussions with UVM and the state on the potential formation for a statewide ACO. And I take the time to tell you all this is that I have seen our healthcare system from a variety of perspectives, and I have worked in it in a variety of ways. And I have learned how critical it is to take an integrated approach to healthcare. And I've learned that the path to an affordable and accessible healthcare system depends on well-functioning primary care, well-functioning mental health and community support services. And I don't believe the AHEAD model is going to help us with any of that or help us get there. At your board meeting on April 17th, you heard criticism of the AHEAD model from several commenters, especially from Julie Wasserman, who offered a detailed critique. You will hear more today, but at that meeting, your board members also expressed many questions and concerns about the AHEAD model, including what the state could do if it did not participate in AHEAD. And I want to share our collective thoughts on that question. We recognize that it is not enough just to say no to the AHEAD model. We need to have a vision for what healthcare reform can be, and we need to have a plan for how to achieve it. Fortunately, we know what needs to be done, and we know how to do it. First, we need to change this conversation. It cannot all be about AHEAD, which will lock in much of the status quo with an untested 9-year model, allowing for little to no progress on Vermont's most pressing problems of access and affordability. There needs to be a comprehensive, integrated plan for all healthcare services. The concept of a total cost of care model makes sense, but only if it includes primary care, mental health, nursing, long-term care, and those support services that directly impact health. And it requires a commitment to make healthcare accessible, affordable, and equitable. We need to have a clear understanding of where our healthcare dollars go today, where there are opportunities for savings, and where we must make investments. Fortunately, there are past studies and legislation that can and should be guiding us. For example, Act 48 was passed in 2011. Where are we in terms of realizing the principles outlined in Act 48? How does the AHEAD model implement those principles? The truth is, it doesn't reflect or directly address them. For example, can Vermonters afford their health care? No. Is our healthcare system transparent in design? No. Is it efficient in operation? No. Do Vermonters have access to appropriate mental health? No, they do not. And I could go on and on. Our current healthcare system realizes very few of these important principles. Why are we not focused on achieving them? Further, what is the status of all the public input gathered last year for Act 167's report on hospital sustainability? I just heard reference to continuing work being done on that. 1,800 Vermonters took the time to contribute their thoughts on our healthcare system. I participated in one of those listening sessions. I didn't hear anyone talk about things like value-based payments. The comments were about the usual and unrelenting issues of being unable to find primary care and the unaffordability of health insurance. How is that public input shaping the planning for AHEAD? I haven't heard that it is. At your April 17th meeting, Board Member Holmes suggested that the board needed to take a deeper dive into cost containment and hospital sustainability. She also stated that cost containment requires removal of inefficiencies from the system, and she mentioned the need to address avoidable care. I couldn't agree more, and I strongly recommend we all go back and read that report on hospital sustainability planning written by the board in 2022. It provides a compelling analysis of the causes of our current affordability and access problems and makes several key recommendations. How are they shaping the planning for AHEAD? The Mathematica study conducted in 2022 identified between 10 and 34% of inpatient hospital spending was for potentially avoidable care. If you look at the individual hospital findings in that report, they mostly range from 10 to 20% potentially avoidable care. But that represents a lot of misspent money. The latest number I have for total hospital spending in Vermont is $3.2 billion. 10% of that would be $320 million. Imagine what we could do with $320 million. That the report estimated that 25% to 45% of emergency room spending was potentially avoidable. Again, a lot of misspent money. If we use that money to fund necessary primary care, mental health, home health, and support services, we could and can reduce and eventually eliminate avoidable care. Over a period of years, investments in those key areas would result in lower spending in hospitals. Then those savings would be reinvested in more prevention. Hospital costs would go down, and so would commercial insurance costs. Then we would have the efficient system called for in Act 48, and healthcare could be affordable. At the April 17th hearing, a question was raised about the prevalence of avoidable care. There's not a problem with avoidable care. I offer the following. A couple of months ago, 4 emergency room physicians wrote a commentary in BT Digger. Their main point was that boarding in emergency rooms has gotten much worse, not just for individuals with mental health needs, but for all types of patients. And they wrote, the answer is complex, but the single largest contributor is the lack of care options for those who require medical rehabilitation, long or home health. Every hospital in the state is caring for patients who could move to another setting if it were available. We know how to solve this problem that the physician spoke to, and it does not require a 9-year-long experiment that is hospital-centric. So just to repeat, there's a lot of money, there's plenty of money in our healthcare system, but a lot of it is being misspent. We can and should redirect that money from avoidable hospitals to necessary community primary care, mental health, and other services to make it accessible and affordable for Vermonters. Instead, we are talking about embarking on another misguided effort that is designed to take up to 9 years and will not address those very real problems that we face. In fact, it is likely to distract us from solving those problems. So what do we need to do? First, we need to strengthen and expand primary care. We need to raise the salary for primary care physicians. We need to provide substantial medical school debt relief, and we need to reduce the administrative burden, especially prior authorization. And I'm glad to see that the legislature is wrestling now with how to reduce the burden of prior authorization, especially for primary care physicians. I would also go so far as to say hospitals should not be in charge of or own and run primary care practices. It only drives up the cost. We should be incentivizing privately owned primary care and FQHC and rural health clinic expansion. Second, strengthen and expand mental health. If there's one thing I didn't used to know and I learned is that mental health and physical health are entwined. You cannot separate them. And that mental health issues that people face either cause or worsen their physical health problems. And yet we are starving our mental health system. And we have been for a long time. So we need more mental health therapists, and early intervention oftentimes should be embedded in primary care settings. We need more mental health emergency services designed to divert people from hospitalization whenever possible. We do not need more mental health acute beds for adults. We do need them for kids. A head is not going to help us achieve that. And then third, we need to strengthen and expand our community services, especially home health. When I ran the FQHC, we also had a home health organization embedded in our FQHC. And I learned quite a bit about what home health can do and how their hands are often tied by regulation or funding limitations. There's a lot more we can do. And as with physicians, we need to train and recruit more nurses system and support them. We need more in-home long-term care services, and including growing the Choices for Care program and funding it properly. Last year that there were plans to cut the funding for Choices for Care. Makes absolutely no sense. We do not need more nursing home beds, though. There are alternatives that people prefer and that are less expensive. If we do these things, we can eliminate most, if not all, the avoidable care in Vermont hospitals today and actually reduce spending in hospitals. And the fourth thing I would say is we need to regulate hospital charges to reference-based pricing, benchmark to Medicare rates, as described by Mark Hage at your April 17th meeting and referenced in his comments by Chairman Foster. The board should use the rate setting authority it already has to achieve this. I would add that by taking this alternative approach, we can address some of the board members' concerns about funding for Blueprint and SASH. I suggest that initially, the funds being used to pay for the administrative functions of OneCare be used to support SASH and Blueprint. It's clear to all of us that OneCare has failed to improve Vermont's healthcare system or reduce costs, and we should repurpose that funding. In addition, S98, which passed the Senate overwhelmingly this year, would expand the authority and duties of the Green Mountain Care Board to investigate and implement ways to rein in prescription drug prices, a critical regulatory reform we need. It's important to note that all these initiatives can occur at the same time with changes in how we finance healthcare services. Global budgets, for example, properly designed, can be used to create more flexibility in how we deliver services and can be a very helpful tool. So why are we not already taking the steps I just mentioned? Because the hospital system prefers to maintain the status quo. Taking the steps above would result in reduced hospital spending and a right sizing of our hospital system as recommended in 2022 hospital sustainability study. The time has come to make these changes. To continue on the current path is simply to continue to fail, to create access or affordability, or for that matter, equity. The alternative approach described here will result in a more efficient, less costly system that provides access to necessary services to all Vermonters and finally achieves most of Act 48. A couple of more comments. First of all, Julie Wasserman, Mark Hage, Deb Snell, Mary Moulton from Washington County Mental Health, and I recently met with CMMI Director Liz Fowler and shared our concerns and ideas. She seemed open to hearing concerns about AHEAD from us and others and said, in effect, that CMMI would not want to proceed with the AHEAD model in a state where there was significant opposition. We believe that significant opposition to AHEAD does exist in Vermont and is growing, and you're going to hear more of that this morning. In summary, there needs to be a comprehensive integrated plan for all health services to determine where to make investments and where to reduce unnecessary capacity. This plan would support strengthening and expanding community services to reduce avoidable care in hospitals and save substantial funding. Spending in hospitals would be more tightly regulated, also resulting in savings. We appreciate all the questions and the concerns raised by board members at your April 17th meeting. We hope the board takes the necessary time to review and discuss them thoroughly before making any decision about pursuing the AHEAD model. We suggest that we should take all the time and energy and money that we're spending talking about AHEAD and planning for AHEAD and put that into the alternative approach I described above. An affordable, accessible healthcare system is very achievable in Vermont, in my opinion, but AHEAD will not get us there. Focusing instead on the fundamentals of primary care, mental health, community services, and control of hospital spending will. And I thank you very much for your time.
It looks like Dr. Malik, you've come unmuted. I'm not sure if other panelists, I presume other panelists had thoughts they wanted to share.
I thought Did you want me to speak now, or I thought you might have questions for the first guest?
Oh, sorry. I think it's fine if board members hold their questions till the end, if that's okay with you all. Yeah, why don't we do that? Please go ahead, and we'll save board questions to the end.
Okay, let me know if there are any audio problems. So my name is Marvin Malik. I'm a medical doctor and have been in clinical practice for the better part of 4 decades. I was trained in medical school in Syracuse, did my residency at the county hospital in Chicago, and have a degree in health policy from Harvard School of Public Health. So I've been interested in policy throughout my entire career. I've spent about half my career in primary care, serving as medical director of a couple of facilities in New York, upstate New York, one of them a community health center, and also a hospital-based primary care facility in Barre, Vermont for several years. Due to the shocking impact of growing administrative burdens and electronic health software, most all of which is dysfunctional, primary care was eating into my evenings till 10 o'clock many nights, always till 8 or 8:30. And I elected to change over and become a hospitalist, which I did until the pandemic. During the pandemic, I worked in primary care through the entire period. So I've gone back and forth and doing a lot of hospital medicine, and a lot of my career has been in primary care. And I just want to say, I think the AHEAD program will have negligible benefit or possibly make things slightly worse. I'll say the one positive feature of it will bring about $100,000 a year for the first 3 years per physician for the first 3 years of the program. So throwing a little more money at primary care is always a good thing, especially given the fact that the administrative burdens on primary care are huge. And I don't know if those of you who are not practicing medicine or are not on my side of that barrier between administrators and medical providers, but the administrative burden in primary care is much, much, much larger than what specialists face. Specialists, if you're an ENT person or a general surgeon, your administrative burden is minimal by comparison. I mean, what is going on with primary care, the administrative costs that are being inflicted on primary care from numerous sources are absolutely huge. And in my opinion, the most gratuitous of the sources of that administrative burdens is this CMMI agency in Medicare. This is an agency that is pretty much 100% failure. And I want to go through 2 pieces of research very quickly that have documented that. At the 10-year point, the CMMI, the Congressional Budget Office did a very careful analysis of the programs, these value-based care programs that have come out of CMMI. And what they found was that the net effect of all the programs, rather than cost containment, was actually adding cost to the system. That they were a complete failure. This is all their programs combined. And that their analyses had excluded many costs, including the cost of the agency itself, the costs they were inflicting on primary care practices, and in some cases, especially Vermont, the costs that were taken on by the state government. And if you just look at the number of personnel hours that the Green Mountain Care Board has devoted to OneCare over the years, this starts to be a lot of money. And for negligible effect, I would direct your attention to the CMS Office of the Actuary, doing an analysis of health costs, per capita health costs over the years, and there's virtually no impact in the states that have been more involved with value-based care, like Vermont and Maryland. They continue to increase pretty much unabated compared to the many states in the country that have been less involved. So these programs have had no effect And the other study I think it's important to keep in mind is Hubert Reinhardt, the famous health economist, did a study in 2003 looking at why health costs in the United States were so high compared to all the other countries. And what he found was that in the other countries, things don't cost as much. Prices were lower. Whereas volume of care, the number of procedures, the volume was accounted for about 10%. We do a little bit more surgery, have a little bit more hospital care, but not very much. And so I think it's very important that the Green Mountain Care Board think about that and go after prices. And just to give you one example, Steve Leffler, the chief medical officer of UVM, was taking some reporters, some journalists on a tour, and he found that he was showing them why costs were so high at UVM. This was when they had a big increase in their costs and had a deficit. He said, well, look at this. Here's a coronary stent, and it's tiny, it's not very big, but it costs $1,300. So that was the article, he said that, and it was true. So I looked up, what does a coronary stent cost in Germany? $350, a quarter of the cost of what Steve Leffler and UVM is paying. And I think if the Green Mountain Care Board wants to do something about health costs, start going where the money is. Imagine if Willie Sutton started robbing lemonade stands. And that's what it is, going after volume of care, like one value-based program, value-based care program after the next. Everything costs too much in the United States. So that would be the other point I would make. I also want to say that I think provider disincentive schemes and the impacts of these value-based care schemes on primary care and on hospital care both have been pretty modest. We have, when I ask other doctors, other hospitals, and other primary care people, so what do you think of OneCare? Even after all these years, all I get is either shrugging shoulders, rolling their eyes, like, what is it? What are they doing? They don't see it. The one thing that OneCare might have done, if the cost of hiring care managers, which used to be funded by the Blueprint, if that cost was shifted to OneCare, then that spending is fine. Having primary care, have mental health readily available at primary care, substance abuse, and care managers, care coordinators, if that's available in primary care, that's helpful. But we don't need this massive apparatus of a head to do that. And speaking of administrative costs of primary care, Liz Fowler is intending to inflict some sort of ACO-like structure, like OneCare, on every single Medicare, traditional Medicare patient by the year 2030. And so we're all going to have to get in bed with some sort of value-based care. It'll be a complete waste of time. There'll be no benefit to health costs, which is, of course, the rationale, but that never stopped CMMI from inflicting more of these programs on us. But I just wanted you to know that a head is not going to count. So every primary care practice that goes through the administrative effort of learning about a head and complying with it, getting involved, if their primary care providers need to take action, change the software so they can click on certain buttons to show whoever's doing an audit of what it's doing to primary care to make the audit look good, that all of those, that clicking of buttons for primary care providers, the head will add some of that, but it won't count, and they'll have to have something else like OneCare or Vitalize or one of these other ACO deals also. So it seems like there is no limit, no constraint on how much administrative burden you intend, I don't mean you personally, but administrators in U.S. healthcare, what you intend to inflict on primary care practices. But it's not good. And it's not good for hospitals either. Wasting time on all this MIPS stuff, and it's just very discouraging. We feel like, you know, you're in this one world of doing all these things that don't work, and we're just trying to take care of patients. Fortunately, we do take care of patients. And just to give one more example, as a hospitalist, I frequently do something which you probably could call coordination of care. I have a case, kind of complicated. I need to talk to a specialist. And fortunately, both Dartmouth and UVM have a phone line for me. And those of us who are generalists, we call this phone line. We can talk to a relevant specialist. They usually call back the same day. We can discuss the case. That's coordination of care. And before there was OneCare, I would get one type of answer. And after there was OneCare, I got the very same type of answer. Nothing changed. OneCare had no effect. The types of things we did for patients was based on their clinical needs. And so OneCare, I didn't see any impact. When, again, as I've asked other primary care providers, what's the impact of OneCare, they haven't a clue. So I think you need to keep this in mind. The last thing I want to say about these value-based care companies is they invariably say that they're working on care coordination. And I just want you to know, they do nothing for care coordination. Nothing. Zero. Nothing is happening. If we have care coordinators in our practice, they help. But these entities do nothing. So all the administrative burden of that a head will entail could just be eliminated if we just had the appropriate personnel to treat the people in our community. Final thing is, one of the reasons, many reasons that a head is likely to fail is that it's only going to apply to traditional Medicare, which is decreasing in number every year due to the overpayments to Medicare Advantage plans. More and more people are taking the bait, the lure, and going into Medicare Advantage. So the the number of people left in traditional Medicare is steadily decreasing across the nation and in Vermont. So that population will be decreasing. You're going to put the people insured through Medicaid, they're going to be in ahead. Maybe of some commercial insurance patients, but really very few of them. So this whole program applies to a minority of patients that any hospital or primary care practice treats. So we're not going to be able to deconstruct any of our billing apparatus. And at the same time, we're going to have to construct one to contend with whatever a head does to providers. And I feel like when Liz Fowler and these people at CMMI, and you guys as well, when you start coming up with these complicated and genius ideas for programs, I feel like do you ever factor in the administrative costs on primary care practices or hospitals? I just feel like you must think that nobody's spending time on this. We're wasting time on this. Do you understand that? And so that'll be the last comment I make. I wish that you would think about that and stop it. I mean, that would be really helpful. On the other hand, on a positive note, I think you should go after prices. Pefla just talked about the pharmacy initiative. I think this is where the money is. And I think you should work on that. I would say the first area, you could work with other states on the drug part of it, pharmacy costs. Why are coronary stents much more expensive in the United States? Can you do anything with that? And that's just the tip of the iceberg. Obviously, all these supplies in the US are costing much, much more. So think about this. How can you go after costs? But the one I really think you should go after first and the most is recruiting. We clearly need to save money on recruiting because the staffing firms, this is a whole mini sector of the healthcare establishment, they are eating up tremendous amounts of money. $40,000 for recruiting a primary care doctor. That's how much money they get. Even much, much more than that for recruiting those who generate a lot of revenue, like orthopedists and general surgeons. They'll get $100,000 for recruiting one. For temporary placements, the locum, the traveler nurses and temporary doctors, locum doctors, they get almost 50%. So for example, a hospitalist might get, I don't know, $160 an hour or $140 an hour or something like that. For these programs, we have to pay about $280. So This is a tremendous amount of money, and I feel like the state should set up a website, promote it, put all of the vacancies, temporary and long-term positions, in one website, promote it, and start making it so that these hospitals, especially the poor rural hospitals, don't have to waste so much money on recruiting. But they need the positions filled, but going through these staffing firms is just a huge waste of money. I feel like if you're going to spend time on something, go after that. Go after some of these costs that we face, and don't just say, okay, here's your budget next year, lots of luck. They're not going to have luck. We need to work on this, and you should do it together. Anyway, I'll leave it at that, and thank you very much for having us.
Should I go ahead?
Please,
Mr. Chair?
Dr. Malik, Dr. Malik, would you mind muting your computer just while Dr. Richter?
Sure.
It's getting a little feedback. Perfect. Thank you.
And you can hear me? You can hear me?
Yes.
Okay. Well, first of all, I wanted to add to the description of my resume. I actually have been a single payer advocate for more than 30 years. Moved here 25 years ago to advocate for single payer in Vermont. But in addition, I'm a board certified family physician and also board certified in addiction medicine. But I retired from primary care last year after but I've continued practicing addiction medicine part-time. I also want to add that my comments are my own, not my employer's. So as I said, I practiced primary care for 35 years, first in the inner city of Buffalo for 10 years, and then moved to Vermont. And I experienced in Buffalo, by the way, firsthand the effects of managed care. A lot of this whole idea of value-based care is basically just managed care, all these same ideas warmed over. We had withholds by insurance companies, and the clinic I was working in actually at the time almost went bankrupt as a result of that. So when I moved here 25 years ago, I got a job in a rural independent practice in Cambridge, Vermont. I want to describe to you what good primary care is. We had 4 nurse practitioners, four family physicians and 2 nurse practitioners. We offered comprehensive family medicine services with the exception of obstetrics. We did not. We offer that. We also did house calls. Our practice was an urgent care equivalent. We were able to do x-rays, suturing, laceration, skin biopsies, uncomplicated fracture management, and some lab testing. We saw patients on Saturdays and took turns taking call. We covered each other's patients when their clinician was out, but we all had our own individual panel of patients and we knew them well. We spent an hour doing complete physicals, a half hour doing revisits, and 15 minutes for simple problems. In general, it is safe to say we enjoyed working together. We took good care of patients. We took time with our patients. And by the way, that was with paper charts. So when this practice started, it actually was started 50 years ago by 3 physicians. And at that time, they were actually able to see an average of 35 patients a day because there was no intrusion by administrative tasks into their day. And they more than broke even with the cost of running the practice and paying themselves decent salaries. I joined in the year 2000. But over the years, the administration of healthcare, as Marvin spoke of, became more and more complicated. The state and the feds, in an effort to contain costs, added more bureaucratic tasks to our day. And over time, we were able to see fewer patients. The practice was also spending more and more money on transactional administrative costs to collect the bills to keep their doors open. And in addition, the reimbursement of independent primary care practices dwindled down to the point where they could no longer afford to stay open. So instead of closing last October, they sold the practice to an FQHC. This is not a unique story. Most independent primary care practices have either closed, been sold, either to a hospital or an FQHC. And you probably won't hear from the doctors working for them now. They're gagged from speaking out about the deterioration of the doctor-patient relationship. It is now fragmented, continuity is disrupted, and they basically won't speak out for fear of losing their livelihood. And in my view, you're looking in the wrong place to save money in healthcare. First of all, primary care represents less than 6% of total costs, and that includes mental health and substance use disorder services. And yet all of the reform efforts, as Marvin said, and quality measures look to primary care to save money for the system. You need to look at where the fastest growing sector in healthcare is, and that of healthcare administration, causing a case of administrative obesity in our healthcare system. I have a slide which I can't show right now because I don't have the technology to do that. But since 1970, there's been more than a 4,000% increase in the number of administrators in healthcare. While at the same time, only 170% increase in the number of physicians. Nearly 4,000% increase in the number of administrators. And at the same time, 170% increase in the number of physicians. I think that says something. What administrative costs? We had a panel of 5,000 patients. So I'd like to just show you, I don't know if you can see this, but about, I don't know, years ago, I asked the person doing the billing to print out the number of insurance companies that we had to deal with in this practice of 5,000 patients. So you can see this is about 1.5 inches thick, and each, there's about 10 insurance company or insurance plans on each page here. And I could keep going, and this would actually wrap around the building that you're in right now. And I don't think I need to go on, but this basically is just illustrative of the ridiculous amount of money we spend on transactional costs in healthcare. So, and keep in mind that when we talk even about prices, the administrative costs in healthcare are baked into the cost of delivering that care. So even if we're talking about lowering prices, those administrative costs consume in total in this at the system level 34 cents of every healthcare dollar. But in addition, as Marvin said, this represents an intrusion into the exam room, an erosion of the trust, and contributes to the burnout of health professionals. It is not lost on medical students either. When it comes time for them to choose what branch of medicine they want to practice, what do we think they're going to choose? They come and they observe, what does a primary care physician do, and what are they forced to work under, the conditions of practice? And they say, I could make twice as much money and actually have time to myself and become some sort of an ologist, right? Dermatology, ophthalmology, you take your pick. So adding another layer of administration and bureaucratic tasks to our place just to prove our worth is not only insulting, it is counterproductive. You don't need the AHEAD model to improve primary care. Now, there are some of the things Vermont has already done that are working. Embedding services within primary care is good. The blueprint, I work with the blueprint. The blueprint adds a nurse and a mental health clinician to taking care of patients with dealing with addiction. The SASH program has been shown to help. You don't need AHEAD to continue those. They've existed before Vermont even started any of these kind of value-based programs, even before OneCare. Let us do the job we're trained to do and get out of the way. We are experienced. We are board certified. We have worked for years. We're good at taking care of patients. Get out of the way. All of this stuff is adding intrusion and giving us less time with our patients. Vermont primary care physicians deliver good care, and our Medicare costs, by the way, are already some of the lowest in the nation. So how are we going to get them any lower? I realize the legislature needs to take action, and we need to implement Act 48, starting with universal primary care for all Vermonters, publicly funding healthcare for all Vermonters without financial barriers, and again, starting with primary care, including mental health and substance use disorder services. What defines good primary care? It's about good relationships. You can't measure that. Having a doctor or nurse practitioner who knows you and whom you can trust. Continuous care is essential. I'd like to let you know that the practice that I worked in, we had baby records in my practice for patients we were still seeing when they were 45 years old. I always found it amusing that I could tell these patients how much they weighed when they were born and when they met their milestones when they were babies. Time with patients is essential. Most people's lives are complicated and it takes time to sort out. But taking time at the end can save money at the other end. Taking time engenders trust, and trust is essential. to get patients to adhere to care, or to take medications, or to undergo testing, or to not undergo testing, or to not take a medication when it's not needed. But patients also need unimpeded access to services. They need coverage with no financial barriers to the most important sector of care, and that is primary care. After all, a practice can be delivering good care, but if the patient has no coverage or has a large deductible, they often avoid coming in until they are in dire straits. They never receive that good care. I have seen people much sicker than they could have been if they had sought care earlier. I've seen people die sooner than they should have had they sought care earlier. That is what is needs fixing before we go traipsing down another faith-based reform effort that is not based on sound evidence that'll work. And I'd like to add, you recommend and you require that we do evidence-based medicine. We do. But you are not doing evidence-based health reform. In fact, the evidence thus far shows with similar models that shows that it won't work. It feels like a version of kick the can down the road, a stalling tactic, quite frankly, a time and money waster. All the while, Vermonters are facing higher and higher out-of-pocket costs, higher insurance premiums for crummy insurance that leaves 44% of privately insured patients underinsured, meaning that a major illness would cause financial bankruptcy. Results in higher taxes and higher prices for goods trying to pay for the failed system of care we have now. Vermonters will be told to just wait to see if it works for the next 9 years. We've heard that again and again with all of these failed experiments. It is a fantasy that the savings, if any, will trickle down to the patients in the form of lower insurance costs. So in conclusion, I would ask that you do as Marvin and I were sworn to do. Above all else, do no harm. Thank you.
Can everybody hear me? Good. My name is Kelsey Stavseth, and I'm the Executive Director at Northeast Kingdom Human Services, which is a designated agency organization that serves Orleans, Essex, and Caledonia counties. And the first thing I wanted to say is thank you for having me and hearing from us, and also see a lot of timber frame backgrounds here, and so I also really appreciate that. One of the great things about living in Vermont. And so I grew up in Vermont. I grew up in this area, it's St. Johnsbury area. My parents still live in Peacham. I worked at Howard Center. I've worked with children, adults, spent a good amount of time in intellectual and developmental disability services. And my lens is really has a community focused. And oftentimes the designated agencies can be referred to as the community mental health organizations, even though our services are broader than just mental health. And sorry, let me just move this over here. So as I said, Northeast Kingdom Human Services is one of the state's designated and specialized service agencies that provide mental health, substance use, and developmental and disability services to anyone coming through our doors, and is often referred to as the DA-SSA system, or the Vermont Care Partners Network. We do this through strategically and geographically positioned services throughout Vermont. This system is considered a specialized resource focused on community-based services for mental health, substance use, and intellectual and developmental disabilities, and is essential to following through on the state's of Vermont's strategic goal of protecting the most vulnerable and creating an integrated delivery system that improves health outcomes and reduces costs. And so when we think about healthcare reform, it is hard to not immediately think of hospitals, doctors, nurses, and clinics. However, as we embark on tackling the toughest issues related to the health of all Vermonters, we need to transform our thinking in how we invest resources beyond our downstream services of clinical care and medical interventions. We must invest in the change we want to see. Community-based organizations focused on the most upstream services have already been shown to have the largest impacts on improving health outcomes and reducing overall costs. We need the state of Vermont to back up their statements with resources to truly make something transformational. Over the last 2 decades, there have been a compelling body of work which emphasizes and highlights the impact of non-traditional community and population health factors that have an outsized influence on traditional health outcomes. The World Health Organization has conducted research that shows that the social determinants of health, like education, housing, early childhood development, social inclusion, and non-discrimination, and many others, can be more important than healthcare or lifestyle choices in influencing health. For example, numerous studies suggest that social determinants or drivers of health account for between 30 to 55% of health outcomes. In addition, estimates show that the contribution of sectors outside health to population health outcomes exceeds the contribution from the health sector. The United States Center of Disease Control quotes the same language on their website and is using it as a central pillar of their work. So too should Vermont when considering healthcare reform. Centering transformation around hospitals and primary care only cannot solve the health issues facing our state, nor can it control the cost of healthcare in Vermont. Please do not misinterpret my words or statements. Our primary care offices and hospitals are critical to Vermonters and are essential partners for all DAs and SSAs and other community partners around the state and need ample investments to provide high quality care. However, the HEAD model does not seem to center or prioritize the social determinants or drivers of health or community-based services, which are not only necessary, but as stated prior, have an outsized impact on health and are often upstream, preventative, and lower costs. One of the AHS slides presented around the broader system for HEAD suggests further discussion of the larger ecosystem. We are concerned that these discussions will not yield a call to action. As it stands now, AHS has had limited discussions with the community-based system of care regarding boosting funding to address the increased human services need that skyrocketed during the pandemic. Despite a surge in need and referrals to the DA-SSA system, we continue to be underfunded, with the network having to go to the Vermont legislature to advocate for any increases in Medicaid, which represents about 90% of total revenues. The DA-SSA system contracts its services through the Agency of Human Services by statute and has been chronically underfunded for decades, resulting in a significantly under-resourced system. HS does not, at this time, have a plan in place for our network to routinely present and discuss budgets. It is noted and appreciated that the certified community behavioral health clinics were mentioned in the HEAD model, but that is far from assured and does not currently encompass a plan to support all DAs and SSAs. Furthermore, having reviewed the HEAD model and representing an organization that actively participates in OneCare, I'm worried this model continues a similar pattern, which will likely yield similar results. When community resources like the DA and specialized service systems are chronically underfunded, people naturally migrate to higher levels of care, like hospitals, which, as we are seeing, strains available services and increases costs. Additionally, costs rise in other parts of our human service system, such as corrections, education, and our foster care system, to just name a few. As noted above, the social determinants of health, or drivers, accounts for up to 55% of health outcomes. What might our healthcare system look like if community investment was 55% of total healthcare spending? It is hard to imagine, but something that we should strive to achieve. Any model to be adopted by Vermont should support, with a plan, the community-based systems like designated and specialized service agencies that are focused and well-poised to support the social drivers of health. For us, this includes regular increases to Medicaid, work on equitable pay structures that bring parity to our workforce, mitigating a migration to similar higher-paying positions in the healthcare field, which then refer acute cases back to the DA. The HEAD model does not seem to accomplish this. Put simply, a system that maintains blueprint funding and Medicare PCP payments without build-out of the rest of the community-based system will not succeed, and we'll be repeating the story again down the road. We must invest in our community systems fully. By doing this, we put Vermonters at the heart of healthcare reform and understand that there are many factors beyond traditional healthcare that influence outcomes, and sometimes more so. This is realized and spoken to. Now we must have action and resources to back up those words if we're going to continue to lead the nation in innovation and fulfill the vision of AHS to make Vermont a place where all people have the opportunity to thrive in inclusive, equitable, and resilient communities. Thank you.
I realize we're pretty much at the end of our time, so I'm happy to relinquish my comments if the board has questions for the other speakers at this time.
Let me just look at the time. We have 45 minutes allotted for the all-pair model extension agreement, which I think will probably be more than adequate. So I'm okay continuing on maybe even another 25 minutes so you don't get cut short. But
That's
thank you.
okay. Yeah, I will keep my comments brief. So first of all, thank you for the chance to address the Green Mountain Care Board on this issue. I want to stress at the outset before sharing details relevant to my work life, that the AHEAD model will not address the most pressing problems I see every day in my hospital that directly impacts the well-being of the people I care for and the nurses who work to care so hard for our patients. I have been a nurse at the medical center for almost 25 years now, 23 of those in the medical intensive care unit. We get many of our patients from the emergency department, which is so overcrowded with sometimes over 100 patients waiting to be seen. We have psychiatric patients boarding an RED, not getting the care or therapy they need, instead sitting in a room with someone watching them 24/7, sometimes for days on end because we lack mental health services. Our hospital is overcrowded due to the extreme lack of primary care physicians and nurse practitioners. Our nurse practitioners have recently been told that they need to conform with this BDO simplification schedule, which only allots them 15 minutes a patient in many circumstances. We recently had to open a unit that was supposed to be permanently shut down to accommodate patients that are ready for discharge, but with no place to go. So we need more long-term care services as well. In addition, RED is providing primary care and pediatric care. That's not sustainable to our patients or our staff. As the only regional level 1 academic medical center, we take care of the sickest patients across Vermont and Northern New York. Many of our physician residents are leaving Vermont because we are not providing any real incentive for them to stay. My own PCP of 25 years is leaving and moving to Maine, and this frankly terrifies me. New employees at the UVM Medical Center, nurses and staff there can't even find a PCP within our own network. As you know, the story that Dr. Epen, when he moved to Vermont, Dr. Leffler had to help him find a primary care physician because he couldn't find one either. So I really just want to take this time to thank my colleagues and Chairman Foster, thank you for recognizing at the beginning all the unpaid time and effort this advocacy group makes to help support patients in our community in Vermont. It's very difficult going to work every day and listening to our patients say they couldn't get the care they need. They end up in my ICU because, as Dr. Richter and Dr. Malik stated, they can't get in to see a PCP. And it's just adding to the additional cost of healthcare in our state. So I want to thank you for the time and relinquish the rest of it to ask questions of my colleagues. Thank you.
Thank you. I have a couple comments and questions myself, and then I'll turn to the other board members. One note, the Healthcare Advocates Office attends every single board meeting I think that I've ever been to. Unfortunately, they weren't able to make it today. I know that they'll watch the tape and probably contact folks if they have additional questions or want to engage further on the discussion, but I want to note their apologies for not being able to attend to today's discussion. A couple just observations and comments that resonated that I wanted to flag. Mr. Flood, you asked a question about where are we on our Act 48 principles and how are we doing? And I thought that was a really good question. And it's something that the board has been working on in the last few years on trying to do a good job of assessing. I think on Wednesday, there will be a presentation by Mike Barber on some draft affordability standards that the board has been preparing. The board has not previously had affordability standards. We had a pretty broad engagement process to come up with a methodology to evaluate and consider affordability in the state. So that's one. I think that's an important step. Another one is access and quality. Those are additional parts of our mission that the board is working on and has been working on improving our evaluation and public discussion of. I think it's really, really important that we have an honest conversation about where we are as a state. And the board, Barabee, myself, others have been presenting to the legislature on a number of stats and information that gives a picture of where we are as a state on these Act 48 principles. And so I would reference a lot of the presentations the board's been giving to HROC and various legislative committees that touch on some of where we are and how we're trying to do and how we're trying to improve things in the state. Dr. Richter, you said you had a question about, I think you called it faith-based reform efforts and evidence-based healthcare reform. I think that's a really important point. I think that when we make a lot of decisions, we want to be as informed as possible, and we want to have the best evidence we can to go forward. And I would just flag a number of comments that board members made on April 1st and April 17th, and that others have made to try and make sure that this is evidence-based and we're making really, really informed decisions, because I personally agree we can't make a mistake on this. And so that's why the board and AHS have been working on trying to evaluate some of the risks, some of the mitigation strategies to really do the kind of diligence that's needed to undertake a project like this. So I just wanted to flag that some of those things that you mentioned about evaluating this have been things that the board has had top of mind and has been raising. I'd also flag that with the first all-payer model, the auditor from the state of Vermont requested the board do an evaluation of the all-payer model. That is a huge undertaking, but I want to recognize that the board staff has been working for several months on doing a return on investment analysis of OneCare Vermont, and including an analysis of additional costs that were borne by the state in connection with the all-payer model. And we're still working on it. It's in draft. It's been something we've been working on pretty intensely. And at some point we'll be finished and it will be made public. And it's a difficult thing to evaluate, but in terms of your comment about evidence-based healthcare reform, that's an important step and we're doing it. It's not going to be perfect. Evaluating the impact and segregating out all the other noise and confounding factors is very, very difficult, but we're doing the best we can. And just myself having worked through that process, it's been really informative about my thinking on the next model. So I just wanted to flag that I think a lot of people at AHS and the Care Board are working really hard on those things. A couple quick questions. So personally, I agreed with a lot of what you said about what we need to do as a state, right? I don't think there's a whole lot of dispute anywhere about trying to get money to support mental health and home health and primary care. A big question is how to do it. And also your comments about affordability are views that I share as well. And if you go back to before the all-payer model, the first all-payer model, affordability is one of the top priorities we were trying to address back then and today. So one of the goals of this is to get more money from Medicare. And I guess my question is, if the board and AHS were able to successfully negotiate for these savings from the first all-payer model, would that change your view as to the benefits of moving forward with the HED? And what I mean by that is I think what we're trying to do is get this savings back from Medicare, and that will allow us to either lower commercial rate increases to improve affordability for Vermonters, or allow insurance companies and others to put additional financial support elsewhere. I recognize that maybe is more indirect than some of you would think is advantageous, but I wanted to hear your thoughts about that.
Do you want to hear from just any of us, or?
Sure. Yeah.
I mean, first of all, I find I've experienced this. I've lived through this in Rochester, New York, where I trained, and in Buffalo, New York, where they had all these kind of withhold contracts, and we never ended up seeing the money that we were promised. The amount of money that they withheld, they never returned. It's, again, still faith-based in my view. This is not based on any evidence at all. We also have the lowest, some of the lowest, I believe almost the lowest Medicare costs in the country. So it's hard to believe that we would somehow gain more Medicare money. I frankly feel that it is too dangerous for us to venture into something based on hope, rather than look at things that we do know will help. And the other issue we have not discussed is expanding patients' access to primary care, not just in terms of having more capacity, but having patients not be afraid to use the insurance they have because they have high deductibles. We've not talked about that. I mean, people are avoiding care, which affects the quality of care that we can deliver. So I don't understand how this really, again, would end up, it sounds like trickle-down economics to me.
Mr. Flood?
A couple of thoughts. First of all, you may recall from the April 17th meeting when your board member, Tom Walsh, said that the whole point of these federal initiatives is to reduce spending. And while there may be some upfront additional money for primary care in the AHEAD model, the end result is that the federal government wants to spend less. I don't know how much is going to find its way back to Vermont to be spent here in other ways, but I would also suggest there is a huge amount of money to be saved, I believe, in what the population that's called the dually eligibles, those people that are eligible for Medicare and Medicaid. They are the most expensive cohort of Medicare recipients. And a number of years ago, I was part of an effort to get a dual eligibles pilot started in the state of Vermont, where in fact, we would be able to respend time kibosh that, and we don't need to go into the reasons why, but it wasn't because it wasn't a good idea. So I think instead of talking about AHEAD, I would much rather be talking about how do we manage the dually eligible population, because that's where the money is. It's not in primary care fees for your average Medicare recipient. That's not, and I think Deb has been very clear about that. We're just having the wrong conversation. The federal government wants to cut spending, not expand it, and they're going to do whatever they can to do that.
My information is, I think you're right. I think Vermont is the lowest Medicare per capita spend state in the country, which could be for a number of reasons. But if the state were able to achieve these savings, and I mean, I recognize the risk that you're citing of actually having it come through the door as opposed to a more hypothetical savings, but I think it would be valuable. It could be potentially very valuable. The other question I had was, so one of the theories behind global budgets is that hospitals are forced or incentivized rather to push on high margin services. So you see really high outpatient commercial prices, and they want to drive margin, and they have financial difficulties. And the global budget takes away that incentive to drive high margin services and allows them the flexibility to provide care elsewhere, more preventative, mental health, primary care, whatever it may be. What is your view of that component of the AHEAD theory?
Well, and first of all, we have an experiment in global budgets back in Rochester, New York, back in the 90s. I'm sure you're aware of that. And basically at that time, they had a complete global budget, and that actually did work. That is really not what we're talking about. You're talking about this global, I guess, a global payment. And I think we need to define what we mean by global budget. A global revenue budget in terms of international systems means that they basically get a payment every month or so for their fixed costs. And so they do have more of an incentive. The problem with when some are paying through a global payment and others are not, is that the people who do not have that kind of coverage or that kind of program, they end up actually absorbing that cost. So that gets cost shifted. So unless you're talking about an entire global budget around a hospital, in my view, this is not going to work. This is, again, it's not, there's no evidence that this will work, a global payment, rather than a global revenue budget. So I think we need to better define our terms.
I'd like to add that you're only talking about a third at most of their revenue, because so many people so many of their payers are not going to be in the system. They're still going to have to, so UVM's still going to have to bill for Adirondack people who use their specialty care. You know, I worked in Springfield Hospital, so we had a lot of skiers come in with injuries. So they still bill for that, and you know, their military programs won't be in it. I don't think the federal employees will be in it. Workers' comp won't be in it. Most of the commercial insurers, 1/6 of the state of Vermont is in ERISA plans. They're not going to be in it. So I think this is, you know, they're still going to have to promote. They're still going to want to promote their high revenue services like knee replacements, things like that. And that's what you're hearing on the radio. If you just listen to the radio, which is their advertising. I don't think this is likely to change that.
Oh, I'd like to add just one more thing. I mean, you have to remember too, are they planning, let's just say people were using fewer orthopedic services. Are you saying that they would somehow eliminate that service or reduce that service? Those represent basically fixed costs. 84% of hospital costs are fixed. So I think it's important to recognize that this because someone is not using a service does not mean the cost of it goes away. We saw that during COVID when people stopped getting knee replacements and people stopped getting a lot of that outpatient care that was, again, considered hospital care. So we can't ignore that. We have to look at this at a system level, which is why, again, I think these experiments will not work.
Can I jump
Patrick
in?
and Kelsey, I see you. Yeah, please.
Yeah, a couple of things. First of all, global budgets for us is relatively new territory, and we have to be extremely careful because while they may achieve what you just referenced, which is, you know, trying to bill for high revenue services, they also may create the incentive not serve people. And that's a really concerning problem. So it requires great care. But I would also repeat what I think I heard Deb just say, which is that it really has to be a system-wide approach. Just giving hospitals global budgets is not going to work, in my opinion, because there's the rest of the system. They depend on the rest of the system to make that global budget work. Doesn't do any good for them to make more referrals to mental health if the mental health system can't provide the service. It has to be a systemic approach. And the third thing I would say is that I think the board needs to take a very hard look at rate setting, and whether it's reference-based pricing or some other approach, because you don't have to have a global budget to bring down prices. And to, you know, those savings can then be reinvested. So it's a very complicated discussion that's not easily answered in a minute or two, but those are three serious concerns.
And I would briefly add to that. So we, in some aspects of the designated agency system, have a value-based care, which is, you know, we have a prospective payment based on per member per month. And so it's capitated essentially as saying, you know, you need to see this many. And so I think that can be a good thing, which is meant to provide flexibility. But one thing I will note is that working with the federal government, we know that what happens is that compliance and reporting is a priority, and sometimes the number one priority, and you get the prove it attitude. And so how did you use your money? And so in my opinion, and some of the places we're headed with some of the stuff, it feels like we're headed towards a capitated fee for service model. And then when I think about global budgets, it does prioritize the financing. And I understand that financing mechanisms often drives care, but I do think a few people have noted that you get these unintended consequences where you may need to invest in somebody, but you don't because it's too expensive. And you do refer out to specialists who then absorb the costs. And so I think that global budgets do have the unintended consequences of shifting costs. And I would recommend, how are we focused on outcomes, and then use financing and incentives to do that. I do think that value-based care and global budgets can force us to risk averse services that don't prioritize innovation. It's about managing your budget when that is the prioritized central feature of payment reform. So I would say be mindful of how that's going to be leveraged and some of those unintended consequences that come from having that captive budget. You may reduce costs, but I think there are those outcome measures that may be impacted because of that. The other thing I will speak to a little bit is the current model of OneCare and how we're included. And so we believe in integrated care, collaborative nature, but we the resources to support being part of that model to do the data, to do the administrative work, we are funded less than a 1 FTE to participate. And so again, going back to that upstream investment, it has not trickled down or come out. It is focused on the medical model, which again needs investments, but I think leaves out a large chunk of investments that could actually reduce costs in the long run, but requires a different type of thinking when we're prioritizing how we go about supporting healthcare reform.
Thank you. I'll open up to the other board members for questions or comments.
Chair Foster, this is Tom. I'll just take a quick moment to thank the presenters today. And as you said earlier, the presentations we get from the public and from advocates is welcomed and thorough and impressive, and I'm thankful for it. A couple things that I wanted to call out that I heard today. One is the continued increasing difficulty to qualify out of MIPS reporting, and that participation in the AHEAD model. I've been looking at this for the past week. It's not clear to me that participation in the AHEAD model will exempt anyone from MIPS, particularly over the next 9 years. It's likely that MIPS reporting will be required regardless. One of the presenters noted that. I also wanted to call attention to the recruiting website idea. I've been surprised in how difficult it is to find jobs that are listed at hospitals and for the state in Vermont. And so that seems like a pretty straightforward thing to do, would be to make it easier for job searchers to find jobs where they meet the requirements. It's try it yourself. It's not particularly easy. And finally, I've been saying for a couple of years now that just like the people of Vermont would like us clinicians to be evidence-based and adjust our practice if the evidence changes, as regulators, we should be evidence-based. We should be looking to do evidence-based regulation. And if evidence changes, then we should change. And the evidence for value-based programs has not panned out. I wrote 2 books about them. I was very intrigued and excited about the idea of them, but in practicality, they haven't worked. The evidence has only grown that our biggest problems are with prices, and regulating prices has the most evidence for curbing runaway or skyrocketing healthcare costs. Several of the presenters spoke about that, and I just want to note that that I heard it. It's same conclusion that I've come to reviewing the evidence, and I wanted to thank everyone for their presentations today.
I have a comment if you have time. The point that Mr. Walsh just made is, I want to reinforce it. You don't see the jobs that are available that are open at Springfield Hospital because advertising is so expensive. When we were down two hospitalists, we did an analysis of trying to advertise in the New England Journal or other places where doctors might look, and it's incredibly expensive, even for a very small ad that very few people would notice. And that's the reason why they end up resorting to these staffing firms that have huge cost, but generally get paid only if they deliver, so that looked good. But I think the idea of having a single site, an online site that you could put out there to residency programs and to other potential users could be an enormous benefit in reducing costs, especially for the small rural hospitals like Springfield and Gifford and some others.
I think that's a good idea. I don't know if it's the role of a regulating body to do it, but I wanted to call attention to it because I think it's a good idea.
I have a couple of quick comments. I did have some specific questions, but given the time, I'll hold those. Maybe I can just email them to the group to get their thoughts on those separately. On the MIPS issue, I did just want to make sure folks knew that the federal government has indicated that they're open to negotiating that issue with Vermont, should Vermont pursue the AHEAD model and choose to do its own global Medicare global payment program. So I think that while the general AHEAD model, I think everyone's right, that doesn't exempt folks from MIPS, but that is a place where we may be able to negotiate. Yeah, and I think the conversation around participation in the global budget, voluntary versus mandatory, and how much revenue can be included is a good one that needs to be continued. I think similar to other sorts of fee-for-service rate setting, the board's authority would extend to potentially defining a global payment program for commercial payers, should the state choose to move in that direction, that would be inclusive of all commercial payers, including Medicare Advantage, as well as others who contract with Vermont's providers. Those were just a couple comments. I'll keep it there, but I did have some questions that maybe I'll just email to Patrick and take offline.
I just want to express a lot of gratitude towards the time and effort and the knowledge and intellect that you all bring to this conversation. I redoubled my belief that the foundation of our healthcare system is strong primary care and community-based services, long-term care, and that we need hospitals to be hospitals and be a very effective hospitals. And I think there's a lot of work ahead. There's a lot of work to do in the future, avoiding the easy to use acronym that's actually hard to use the non-acronym version of. Anyways, I really appreciate this conversation. I'll probably follow up with people individually on some specific things, and thank you so much.
Yeah, I don't really have much to add other than appreciation, gratitude. One of the things that I'll just add one small thing. I think we heard the theme over and over again about the need for more long-term care and mental health services. And I absolutely 100% agree, community care services. So one of the things that I thought I heard Mr. Flood say is he did not think that we needed more beds for mental health and long-term care. And it occurred to me that I would love to see an analysis, not by Mr. Flood necessarily, or I would love to, but I'm not sure that that's, your area of expertise, Mr. Flood. But I'm wondering from AHS or from other colleagues who are really looking at the system and what our capacity needs are and where they're unmet. We certainly are hearing about patients boarding, awaiting care, awaiting getting beds. So I'm curious, and actually I welcome Mr. Flood, if you want to weigh in on this, I would welcome it. But I'm realizing that I think it would be helpful to understand, is it additional beds that we need, additional services that we need? How do we start to meet the unmet need that we're seeing throughout the entire state? And so, Mr. Flood, I see your hand raised. I welcome your ideas here, and I'm wondering what kind of analysis we actually need to be able to.
I'll be very brief. I'll be very very brief because you don't have time, but I believe actually these are my areas of expertise to a large
Okay,
degree. and
sorry. Yeah, I just wasn't sure if you had the data to be able to analyze it yourself. That was my point. Not that you don't have important insights, but
No,
whether
no,
you
it's
have the
fine.
data to analyze it. Yeah.
I would just say that we have misconceptions. First of all, about long-term care. One of the problems is not that we don't have the beds, it's that we don't have the staff.
Okay.
And I believe very firmly, and I believe we can demonstrate that we can keep people at home or in an alternative setting much more cheaply than in a nursing home. And that's where people want to be. I recently saw that the cost of a nursing home bed, a daily cost is up to $250 a day. That's phenomenal to me. You multiply that times 365, and we can keep almost anybody at home for that kind of money. When it comes to mental health, when I was the commissioner, and we really had a problem with this because the state hospital was closed. The biggest issue to me always was, how are we intervening ahead of time and not letting people get into such severe crisis that there's no alternative but to send them? And I think we've starved our mental health system. We used to have a much more robust emergency services approach. And I'll just leave it there, but we have got to look at the community interventions that are cheaper and better for people than letting them all filter into a hospital unnecessarily. And so that's a very long, I'll be happy to talk to you in more detail.
I would love to talk to you in more detail about that. I think it's really important, and I think we need to get to the bottom of where we can start to fill those gaps, where the resources should be reallocated to meet needs. So I appreciate that, and I'd love to follow up with you at some point.
And I would just add to that and offer, I'm sure the designated agency and Vermont Care Partners would love to come and speak to that. I think we have a lot of expertise in that area and can add a lot of data and perspective. So I would offer that as well.
Appreciate it very much. Thank you.
I would like to also add that I work in the addiction field, and what is a huge gap in our ability to provide comprehensive services to those suffering with substance use disorder is a very long-term residential treatment. It takes about 9 months for the brain to heal from cocaine addiction. We are seeing actually cocaine is surpassing opiates now in terms of abuse. Again, we have a lot of hospital beds. We probably have more hospital beds than are needed for a population of 600,000. Changing the skill and the intensity of those services and increasing in the area of substance use disorder and mental health, as Patrick had said, would be
It's
very
actually
helpful.
probably in decent shape if you want to.
I've never tuned it, but it's not like terribly.
Hey, Miss Sawyer, I think maybe just mute.
So it's just sort of an aside, again, that those services are probably not talked about because I think, we're seeing all these other needs in the community, but we are paying for those people one way or another when they need replacement heart valves for injecting drugs and in getting subacute bacterial endocarditis, et cetera. And a long-term rehab or residential treatment is necessary.
Okay. I'll do a quick public comment and then we'll have to move along. Is there any public comment via the raise the hand function? Miss Goodwin, how are you?
Good, thanks. I'll be brief. Just the same way that you can decrease the need for beds for mental health. As a physical therapist, we see a lot of people who fall and get into the hospital and then need a bed in the extended nursing facilities. So preventative care using physical therapists is a way to do so. Same with before they go into surgery. We have worked with patients prior to their surgical intervention, like a total hip or total knee, and they are far less likely to end up in an assistive living situation. So keep that in mind. I feel mental health and physical health being connected and similar in same ways that we could benefit the healthcare cost crisis. Thanks.
Thank you. Thank you. Any other public comment? Okay, well, I'd like to thank our panelists again for taking the time to share their views and voices with us and all their educated experience and insights. It was really valuable to everyone. We're a little bit on time, so we'll just keep moving along rather briskly here. The next agenda item is the All-Pair Model Extension Agreement for 2025 and a potential vote, and I'll turn it to Michelle Degree, our Health Policy Project Director.
Good morning. I'm just going to get my screen set up. And can you all confirm that you can see that and you can hear me? I see nodding heads. Okay.
Yes.
Should be hopefully relatively quick this morning. As you stated, I'm here to discuss the follow-up from the 17th, the meeting on the 17th, to discuss the all-payer current model extension through 2025. I left my background slides in, so just a reminder where you can access these materials, the original agreement, the 5-year term from 2018 to 2022, the first amended and I'm getting some feedback. Is that better? Okay. First amended and restated agreement, which was a 1-year extension with an optional year, which we did exercise. And then this is the amendment to the extension agreement for 1 year for 2025. Again, the proposed changes are updating through 2025 to 2025 throughout the document itself, and then includes those new benefit enhancement waivers, which I discussed on the 17th. I've also included them as an appendix to the slide deck if you'd like to revisit those. And it requires the board to use regulatory authority should the ACO make a decision about asymmetric risk. Again, those slides are in the appendix if you'd like to reference those. We received one written public comment outside of the meeting on the 17th from Health First in support of the extension, focusing mainly on the impact to CPR practices. And that is all I have for you. So next steps are, proposed vote for today, the 29th. Again, the fully executed amendment signed by all parties is due back to CMMI by Wednesday, May 8th. So that's next Wednesday. Any additional questions from the board? Yeah, sure.
Yeah, any board member questions or comments? And if there's go ahead with any questions or comments, and I guess I'm curious if board members are prepared to vote.
I'm prepared to vote, and I'm happy to make a motion when folks are ready. I don't have any questions or comments.
I don't either.
I am
prepared to vote.
I'm in a similar situation, although I would say I'm looking forward to seeing the finalized version of the ROI on OneCare, which is not the APM. I think that would be helpful to understand, but I think for the foreseeable future, I think I support extending.
I think I'm prepared to vote as well. So Member Lunge, if you'd like to make a motion.
Sure. I move that the board approve executing the current amendment to extend an additional year under the all-payer model agreement.
I will second it. I'll make the observation that the board has made a number of comments about this, I think in the last or 2 weeks ago, April 17th hearing, and we received some public comment relating to this as well since then. I'll open it up to public comment before we take a vote.
I don't think I heard a second. But maybe
I seconded.
Oh, well, sorry. Great, thanks.
Okay, seeing no public comment, unless there's any other board discussion. Seeing none, all those in favor of the motion say aye.
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 Aye. Member Walsh, are you a nay, abstain, or an aye?
A nay.
So the motion carries 4 votes in support and 1 vote against. Thank you very much, Ms. Degree.
Thank you. Chair Foster, I'll be in touch with you on finalizing those documents today.
Great. Great. I'll call you after this. Why don't we take a 5-minute break, and then we'll turn to our last agenda item, which is our monthly ahead update. So we'll be back at 10:45. Thank you. Is Miss Barabee here?
Yes.
And Miss Garavich?
I'm here as well. Good morning.
And I know we had a little bit of a scheduling issue with Miss Jones. I was not sure if she was able to stay at this time. Is she here? All right, I'll turn it over to Miss Barabee and Miss Garavich for our monthly ahead payment design update.
Great. I will share my screen. Please let me know when you can see it. Everyone see my screen? Great. Okay.
Yes.
Okay, so this is an ongoing conversation. So I'm Elena Barabee, Director of Health Systems Finance at the board, and I'm joined by Dr. Shule Garavich from Mathematica today. And so I'll do a quick introduction and then turn it over to Shule. Initially, we had hoped to get to executive session, but I think there's been a lot of other content today, so we will push that component likely to Wednesday. And if we don't get through all the material, we'll kind of pick up Wednesday where we left off. So I'll try to be brief and run through the intro that you are probably already familiar with, but just to kind of ground you in our conversation again, we've been speaking about the methodology that's being developed for the Medicare, the Vermont version of the Medicare Hospital Global Payment. We kind of took a step back last time we met and now are kind of getting back into the weeds on some of the adjustments and how that might compare to a fee-for-service alternative and how that compares to the Medicare off-the-shelf global payment design. We have to kind of get through this material rather quickly if we're going to meet the deadline. So I just wanted to highlight that we have to submit by July, but we really need to be decided on kind of what this looks like by June 1st. And then kind of to reorient you in the broader scheme of the work happening around the AHEAD model and the different components. So while this specification needs to be delivered, so first we'll work on the methodology paper and then kind of the nuts and bolts of how it works and how it gets calculated as kind of step 2, that specification paper needs to be delivered in July. But that's just the start of the negotiation. So I think for the next year, you can continue to discuss with Medicare, kind of hammering out those various components and discussing some of the issues that had come up today. But this is just the Medicare piece. I just want to draw your attention. The Medicaid global payment implementation is currently targeted for January 1st, 2025. There's also the question of the commercial hospital global payment, which would be required to be implemented under the AHEAD model by January 1st, 2027. And we need at least one commercial payer by then. But it does give the state some time to think about how it would design and establish such a methodology. And then the state agreement is really not until next summer. So there is, some time to kind of flesh out some of the analyses that would kind of help us understand whether this makes sense for Vermonters. So to kind of focus on this piece of it. So again, this is, the board vote needs to be conducted by June 1st to allow time for the development of kind of the nuts and bolts specification for how we would calculate this methodology. But you'll have another bite of the apple. So just because you vote on a methodology doesn't mean Vermont has to sign up for it. And the board votes and is part of the discussion on AHEAD where you'll kind of weigh in on whether or not you think it's a good idea to move forward by June 30th, 2025. So there could be a lot of work that then happens subsequent to the submission of the specification up until the negotiated final agreement. Just a quick reminder, it's a lot of text, but where the board's authority is and kind of our role in this work. Act 167 kind of underscored and kind of gave some specific direction to the state and various agencies, but I'm focusing on the Green Mountain Care Board's role here. Section 1 indicated that Green Mountain Care Board shall develop an all-payer value-based payment, including hospital global payments, of course, in collaboration with AHS and the Director of Healthcare Reform, and determine how best to incorporate value-based payments, including global payments, into the board's regulatory process. This is our work. and then identify potential opportunities to use regulatory processes to improve hospitals' financial health. Recommend a methodology for determining an allowable rate of growth in Vermont hospital global budgets, and consider the appropriate role of global budgets for Vermont hospitals. So that is the work that you're doing now and over the course of the next year. Some relevant authorities, you know well the Hospital Budget Regulatory Authority, regulation of provider payments. So we don't currently implement this authority, but we do have authority in an all-payer capacity, and then the oversight of payment reform. So just wanted to note those for your consideration. So I will turn it now over to Shule, who will walk us through more detailed understanding of the ongoing adjustments that are being contemplated, and hopefully we'll be able to get to your feedback, if not today, then by Wednesday. So Shule.
Thank you, Alina. So before I start, what would you prefer, Chair Foster? Should we stop and allow questions, or should I go through the slide deck?
I think just go through the slide deck, and if board members have questions, they can pop in, but I think given the amount of material, let's just try and proceed.
Okay. All right, sounds good. So next slide, please. So I wanted to first thank everyone who's been participating on this process, and we had formed a technical advisory group that met 15 times since last year. We met with several hospitals, VAS, payer meetings, and Office of the Healthcare Advocate. Everybody gave their time and effort and helped us to think through design questions. So rather than thinking through the big picture, we really delved into the details to prepare for this moment where Vermont could propose state designated methodology to CMS. I also like to thank Director Beruba and Pat Jones and the commissioners who have been helping us to think through these questions. As mentioned, the devil's in the details, so I'm going to go into a very deep technical detail sometimes. Please help me to communicate that at the level that you'd like to have, so we could have a valuable conversation and move the methodology forward for the work that you are preparing at the end of May. Next slide, please. So we combined the prior presentation into a single slide deck. So this is taking from the beginning to the end. So we will be iterating on the slide deck, but hopefully one version of the slides will help you to understand the concepts and where we are with the methodology. As you all know, the idea behind global payment is to provide predictable fixed payments to hospitals adjusted for medical inflation, expected volume changes, and performance. So instead of getting a fee-for-service based payments, they get a payment that is based on their revenue base and updated every year based on the policies and methodologies agreed upon. Compared to fee-for-service payment, where the revenue is depend on number of units and the prices, the global payment methodology is incentivizing to reduction in hospital utilization, increase market share, perform better on quality and effectiveness, and provide additional services without claim-based payments like population health, and focusing on reducing operational cost. We talked a lot about the fee-for-service payment, where the incentives are towards creating higher commercial payment rates, increased utilization, and also focusing on growing high-margin services. Next slide, please. We had initial discussions around the approach to create an all-payer global payment methodology. And based on the feedback, we have been working on developing payment approaches for each payer level. So in this slide, what you're seeing is we focused on Medicare fee-for-service, in other words, Medicare traditional. To develop the methodology, DVA is working on a Medicaid global payment methodology. And then for commercial payers, the initial concept is to develop a payment for each commercial payer at the payer level, which will include all their plans that are included. So if you think about Blue Cross Blue Shield, we expected to have a global payment from Blue Cross Blue Shield of Vermont that will cover all included plans that will include Medicare Advantage as well as fully insured and ASO. I must note that we quickly switched to a focus on Medicare fee-for-service, so our commercial payment methodology is not developed at the moment. As you're thinking about different payers and their dynamics, while Medicare may focus on avoidable utilization, you may think about focusing on commercial rates as we are thinking about the commercial methods. Regardless of the methodologies, we would expect that some revenues will not be included in the global payment, and the JMCB's hospital budget review will include both the global payment revenues as well as excluded hospital revenue as you currently do. Next
So I'm
slide,
going to
please.
violate my own sort of suggestion here about questions.
Go ahead.
So is the regulatory review process, at the end you have the budget review. Does the board in this vision set the global budget for CMS for the Medicare? Then Medicaid does its own. Then is the board setting the commercial global budget for each commercial payer that's in the global budget?
So the methodology, I believe, board is working on the methodology. So board is setting the commercial payer global payment through the methodology. Right. And then once that calculation is done, you will see what the actual global payment amounts will be based on the approved methodology. So every year there might be decisions that the board could take to determine the global payment for commercial payers as well as CMS calculations.
So we have one methodology for each commercial payer?
Yes, that was the intent, but as I said, we haven't got into detail on how to do commercial payers. Yep.
Okay. And then is the idea we add all of these buckets up to come to the budget as opposed to set the budget and then, okay, thanks.
Yep. It could be both ways, right? You could still start, maybe next slide will help in thinking. I'm a numbers person, so I think with the numbers better. So if you go to the next slide, maybe that will help as well. So right now, the hospital budget review is at the top line, total NPR, 3 billion revenue, and the board sets, as you know, the maximum growth rate. You could still do that, but underlying the, how to get to the limit, you could think about Medicare calculations done through the methodology as opposed to right now projected by the hospitals, right? So there will be calculations done to estimate what the Medicare revenue is going to be. So as you're thinking about your budget review process, the global payments will be determined by the methodology. So for participating commercial payers, you will have that number based on the methodologies as well. And certain decisions in the commercial methodology or CMS methodology may be impacted by your HBR review and the numbers you are setting in the hospital global budget review. Does that clarify or confuse?
That's helpful. Thank you.
So in terms of the included, excluded, so this we estimated what is the potential revenue if we were to have global payments for all payers, where we are going to be in the included revenue. So as you see, the percent revenue included is from 67% in 2020 to 69% in 2022. The largest revenue excluded right now is the physician revenue, which is 16%. And the input we received from the TAG and others is that they would like to see physician revenue included in the global payment to align incentives and increase the revenue included in the global payment. But in our phase one, we struggle to get a good estimates on physician revenue, and this is the physicians employed or billed by the hospital. So these are in the hospital revenue buckets. So that will be in phase two. If you can get good estimates and processes to link the physician payments to the hospitals, that 16% could potentially be under global payment as well. However, yep.
So But I was worried you might move on. Before you move off from this slide, can you clarify for me? I think that the teal global payment revenue line is the sum of the 4 lines that are below.
Yes.
Is it? Okay.
Yes.
Right.
However,
And-
that's a maximum,
Right.
right? Because we don't think on the commercial payment that 34% of the hospital revenue is in commercial hospital only. And depending on how we set the commercial budget methodology, there may be some exclusions in the commercial bucket as well, right?
Yep.
So we would need to think it through. So this is the maximum amount that we could potentially include in the global payment.
Right.
Patient portions will never be, sorry, go ahead.
No, I think I interrupted. But based on what you were saying to Owen a moment ago, we'll be negotiating a method for assessing Medicare over the life of the agreement. And we'll be developing a method for assessing and monitoring commercial over the life of the agreement. And each commercial payer could have a slightly different agreement.
Potentially, but
Right.
you could have a single methodology and you will be calculating the global payment, not assessing, but you will be calculating based on the methodology, what that
Yes,
amount is.
and the methodology for the commercial payers, our selected methodology could include, for example, reference-based pricing.
Yes.
Right. All right. Thank you for clarifying. Just wanted to make sure I understood and was following.
Hey,
Could I
Shule?
just jump in with one clarification to your comment, Tom, which is it would be the state authority that would be exercised for commercial. So that could be shorter or longer than the agreement with Medicare. That's up to the state.
Okay. Okay. Thank you, Robin.
Where is Medicare Advantage revenue reflected in this chart?
Great question. So this is coming from Adaptive, and when we looked at the Medicare claims, we are not able to I think it's both in the Medicare fee-for-service line, because we find out that some hospitals include Medicare Advantage in their Medicare in the Adaptive data, and some of them is in the commercial. So in this table, it's kind of split between the two areas. But when we think about Medicare, we are thinking about traditional. And there is about 200,000 difference between what we estimated from Medicare claims versus what we see in the Adaptive data.
And is it an accurate impression that I have that we will not be able to get Medicare Advantage into the global budget, or can it come in through the commercial component?
And maybe, these are great questions, but as I mentioned, we haven't worked through the commercial methods and how it could be implemented. There might be ways to include Medicare Advantage in the commercial bucket, depending on how the regulations are set.
And I'll just note that in the conversations with Medicare, they see Medicare Advantage in the global budget context as being subject to state authority around commercial rate setting potentially.
All right.
Well, one last clarifying question here. Physician revenue for Medicare. Sorry, this physician revenue line, does that include Medicare physician revenue and commercial physician revenue?
And Medicaid, all payer.
And Medicaid, right, yeah, okay, great,
Yeah.
thanks.
Okay, next slide, please. At the end, we can think about why global payment, and depending on the view from each side, there might be potential gains and unintended consequences, as we've been discussing. But from the hospital's perspective, it needs to align with their mission and leadership view. And if the hospitals are going to expected to invest in population health and reduce avoidable utilization, I have heard that some hospital leadership, not in Vermont, as you know, I've been working with several states on the global payment, that some leadership of hospitals think that their role is really to take care of the patient when they are at their within their walls. So that's the leadership and where the hospital would like to invest their resources. From the financial side, it provides predictable revenue, and it's also a way to fund fixed cost as the methodologies account for changes in utilization in a different way. We haven't focused a lot because we are working on the financial methodology, but a lot of the gains actually could happen on the operational flexibility, where we could get waivers on 3-day rules and other things that kind of prevent that continuity of the care from the Medicare perspective. Transformation incentives and upfront funding for service line changes are from the hospital side could be potential gains of the global payment. For states and payers, as you all know, the hospital cost is the largest bucket of healthcare care. And how we can control this cost while transforming care is from the states and payers' perspective, may attract them to global payment. A lot of other states have focused on their safety net hospitals. They see global payment as a stabilization method where the rural providers and safety net hospitals receive the global payment and create the predictability for their spending as well on the states and payer side. The patients, what is it for the patients? If we can get the payment model right and invest in transformation, the ultimate goal is really to coordinate care better, increase primary care and prevention, and focus on social drivers of health while providing better quality access and potentially, again, look for benefit enhancements for patients. So these are all depend on how you do the details, right? So at the highest level, global payment, as I mentioned, have the large incentives, but the methods will drive the outcomes that you seek on the global payment. Next slide, please. As you know, where we start, the goals should drive what we do in the methods. So if the goals are to rebalance the system and invest, sorry. Was there a question? Okay, so if the goal is to rebalance and reduce avoidable utilization while investing in access to essential services, the finance needs to be combined with the transformation support. And again, we are going to be just looking at the finance at this point. Next slide, please.
Shule,
yeah.
Can you go back to that? I'm sorry, when I was reviewing these, I was just having a hard time understanding how the scale analogy in this, there was sort of investment on both sides. So I was trying to understand, maybe, could you just explain this left component of this again?
The scale in terms of the investment, reducing avoidable versus investments in access to care.
I guess often we think of like a balance in these situations. If you reduce avoidable utilization, then that things are in a balance, so that if you decrease cost, you increase expense. So this one is we're investing, and I'm trying to understand it. I mean, I guess I get the concept, but I was trying to figure out the interrelationship. Maybe it looks like if we invest in population health, then hopefully we'll reduce avoidable utilizations. And then if we invest, which will then, but that's sort of investing in to improve essential services will reduce the avoidable utilization. Anyways, maybe I just understand that the scale analogy doesn't maybe fit for me here.
I see. Yeah, I think maybe I'll think about a different visualization, but the idea is we have two objectives, right? Controlling total cost of healthcare, making it affordable. But we also know we have access problems, so we need investments. So at this point, they are driving the scale in different directions. So if we invest in access in the short term, we need more funding. If we are trying to control and make it affordable, we need to reduce funding. So the only way is really to figure out how we can transfer resources from one side to the other. in the long run. And the way the global payment, think about is under the global payment, if we can reduce the avoidable utilization and funnel that funding to access, then we can have that overall balance. But you're right. So the scale is not going to get to an equal.
Can you go back one more slide while we're here too? And just this slide's really helpful, I think, in identifying a lot of the potential benefits of a global payment. But I think what we don't have, I think, to balance this are sort of what are the potential risks or downsides of a global payment. And I don't know if you could build out a slide to sort of balance with this, or if you want to speak to some of those things. But I think that, you know, there's in each of these categories, there's risks of a global payment that I think we have been trying to struggle with a little. We've been not trying to struggle with, we've been struggling with and trying to understand.
Yeah, I do have slides at the end. I wanted to go through the details so you understand some of the mitigation strategies. Towards the end, we are talking about the risks and unintended consequences. There is no silver bullet, right? So at the end, in terms of thinking through why and why not, we need to think about the risks as well. So I do have slides towards the end, but I thought maybe it's better if you go through the details so you understand a little bit the methods before we think about the mitigation strategies or where the risks are. If you don't mind, I'll keep the order.
That's right. Maybe in the future, if this comes up, it could be a place where we can sort of have that. Yeah.
Right after. Okay. So in terms of the Medicare, we talked about how the Vermont spending on Medicare is much lower than the national, which we think through the negotiations, a HEAD model could provide additional funding to the state. I wanted to show you the slide. So this slide compares Vermont to national. It's all Medicare fee-for-service beneficiaries. As we talked about, the average HCC score, which is the health status, Vermont is about 18% healthier based on the risk scores that are calculated based on the claims. And on the utilizations, Vermont utilization is much lower in almost everything except ED visits, which is 5% higher, and hospital outpatient visits, 77% higher, and the rural health and FQHC visits, which is 219% higher. You do see that the distribution of the visits are different in Vermont, but in general, most of the visit counts are much lower than the national average, even after you take into account that 18% healthier population. I do want to point out that the HCC scores are a function of utilization as well. So when you think about the risk scores, if you use hospital services more, the HCC score is going to record you sicker. So there is a function a little bit here, chicken and egg issue, that if the utilization is low, you would look healthy, regardless of what the actual underlying health status is. The next slide is looking at the payment levels. So this was the utilization, and now we have I apologize for the a lot of numbers here, but what we did is we looked the Medicare standardized payments per beneficiary. We restricted to 65 plus. And here you can have the comparison of Vermont to other New England states as well as national. And you do see that the Vermont spending is lower in all of them except the FQHC Rural Health Clinic, which is much higher than any other New England state as well as national. I'm gonna, so those are our starting point. We have lower utilization and we have lower payment on the Medicare side. As we're thinking about the global payment methodology, what we are going to do in the methods is we would need to come up with a base. And the base is a 3-year average or 2-year average of the historical payments and additional incentives that we could hope to build into those baselines to invest transformation and healthcare delivery reform. The next three steps here is as we update the budget over year, we would need to update it with medical inflation and CMS policy changes. We need to consider utilization changes and performance to come up with this prospective global payment for year one. And every year, these three last buckets will be updated based on the methodologies and based on the numbers that are produced by those methodologies. So that's the concept. As we think about the CMS methodology now, with the stakeholder process, we've been building this. And once the CMS published their methodologies, we did quick comparisons to understand where we are different and where we want to keep the difference. So your input is going to help us to figure out the variation from the CMS methodology and the negotiation strategy with the CMS. So I will be doing back and forth between Vermont methodology, CMS methodology to give you a context, but hopefully we'll make progress in terms of the decisions for the Vermont methodology. So the first one is we talked about physician revenue that is excluded in our phase one. There are additional exclusions that the CMS methodology is applying. So this is a lot of detail. I'm not going to go into the detail buckets, but initially the TAG input was to include as much revenue as possible to have the incentives aligned and maximize the global budget payment included in the methodology. There were also concerns raised that the high-cost services need special treatment and potentially should be excluded or adjusted under global payment. The CMS, if you go back to, you were doing great, sorry. If you go back to one slide back, when CMS published their method, so they, the number three, I'm going to start from number three and go through number one. Number three, we are all aligned. Additional payments hospitals receive on bad debt, graduate medical education, etc. They're all excluded from the global payments. So there we are aligned with the CMS methodology. Number two is a detail where these payments are included in the initial payment and then reconciled to fee-for-service at the end. We are not aligned there with the CMS. The biggest one is outlier payments that the TAG input was to include everything, right? So outlier payments were included in there. And the last one is that CMS really split the payments and excluded additional payments related to distinct parts, method 2 billing, etc., outside of global payments. So we have two exclusions. One, continue to pay on fee-for-service. Two, pay in the upfront monthly payment, but reconcile at the end. From my perspective, incentive-wise, I would consider 1 and 2 both excluded from global payment. Any questions about that?
So I could, well, go ahead, Dave.
I just, one thing I'm trying to understand with this. So say if I was a patient who had Medicare and went to the hospital, say for an emergency department visit, had some chest pain, they had an outpatient testing, how about an outpatient stress test follow-up? So in the global payment would be the facility fees associated with the ED visit. Mm-hmm. And the physician fees would still be in fee for service for the for the next period of time X, we don't know. And then when it moves to an outpatient setting, similarly, so, but then as a Medicare patient, I would be on, for my copays, I'd have my ED copay and then my 20% copay for physician services. And I believe it's a 20% copay for the outpatient services. So there still needs to be a generation of a bill to determine the fee for service component, because the 8% patient paid services are going to still kind of exist within a fee for service rubric. Is that right? So there's like there's going to be a fee for service background running that's going to then charge the patient for their component of it. The physician component still is in fee for service, and the facility component, kind of the idea of paying for the fixed costs of the facility, would fall under the global payment. Is that
Right?
Am I okay?
Yes, exactly.
Sorry, Robert.
And
That was
facility claims will go as it is. Facility hospital is no longer going to get paid on that claim because they are getting monthly payment. But the physicians are going to get as usual. And for patients, their calculations will be done as usual as well. No change to physicians and patients. It's going to be only the hospital bill that will not get paid under global payment because they're going to get monthly. But with the exclusions, if you go to the next slide now, if you are a complex patient, so in this slide, what we did is we modeled the CMS exclusions. And here, what we have is the 691 million claims payments to Vermont hospitals. And 17% of it is the patient or secondary payer payments, right? So those are not changing, staying as it is. So we will not include them in it. The DISH, UCC, IME are additional payments that we align. So that is about 5%. And the subunits, these are rehab and psych beds. If you are a patient admitted to those units, you are still going to be those services will still be paid on the claim. So it's a fee for service. The outliers is, in your example, if that patient gets a heart surgery and it's a very expensive patient, CMS is going to still continue to pay that difference of the high cost. So that's about 4% on the PPS hospitals, and we are not able to calculate that for critical access hospitals. And finally, on the biggest exclusion for the CMS is the outpatient carve-outs. These are the oncology infusion services that CMS is going to pay still on a fee-for-service claim. We had, if you think about access concerns and incentive not to admit high-cost patients, CMS exclusions is moderating that by excluding those from the global payment. So there is no change in the financial incentive for those complex cases or high-cost infusion services that the hospitals are providing in the outpatient setting.
Shuli, can I just ask a quick question about this and how this reconciles to the slide? I think it's slide 11 or 12. That 691 that you have, the 65%. How does that reconcile back to the amount of revenue that we anticipate being in the global payment? Is that already
Great
factored
question.
in?
I didn't do that, but this was in the adaptive one. So this is our initial point, but we didn't add those back in. As I mentioned, 781 million that we see in the Medicare fee for service based on adaptive. On the claims, we are seeing it about 690. So we have 100,000 difference in our Medicare estimate. We had already excluded the 17% from that one. So that's already taken care of. So if you like, we could update and send you an updated table. So you could see that in the next phase.
Okay, thank you.
Any other questions on this one? So as you're thinking about the magnitude, that's 65%. The other way to think about the excluded revenues, are they going to grow faster than the rest of the services? So in this table, we provided you with a growth rates for those main excluded services in the CMS methodology. So I will walk through the PPS line first. So when we look at the included revenue for PPS hospitals in 2023, they grew by 7%. So this is unadjusted. That includes inflation and utilization together. So when we look at the inpatient outlier payments, so these are the high costly cases, and there is a complicated methodology for CMS to do this. Those also grew by 7% in the same period. So growth rate wise, if you were to include them in, they are growing the same way. There is no potential impact on the finances if the rate continues. The outpatient carve-out, so these are infusion drugs and some other exclusions. So they've been growing a little bit faster. So that's an 8% growth. on the outpatient side. And the subunits are the ones that grew much faster, so 12%. Including all these things in means that they're going to get average growth rate. Excluding means they're going to be continued to paid on the fee-for-service trend, whatever that would be. For critical access hospitals, their revenue declined by 1.5% in the same period. And when we look at the subunit payments, you see that they have 18% drop in the subunit payments. So from the critical access perspective, getting average to both of them would be beneficial for critical access hospitals. For PPS, excluding them would be beneficial from the finances perspective, if the 23 trends continue. Moving on to the next slide.
Shuli, I'm sorry, before you move on, so I think just to sum up, it seems like what CMS was looking for in terms of their exclusions was to ensure that if there was an incentive to shift high-cost services either to another hospital or from perhaps a smaller hospital perspective to a bigger hospital, they were looking to counteract that incentive by excluding those higher cost services. So, so one way to look at this is if Vermont is concerned about that same dynamic, we may want to stick with the CMS methodology. So is that, I guess I'm looking for confirmation that I'm thinking about this in the right way. It's not really a question, it's a, did I understand that?
That's correct. So outliers, right, the complex cases, so there's no longer incentive not to admit. And then the outpatient carve-outs usually includes expensive drugs, and Maryland does special adjustment for their drug cases. And this has been a kind of an issue under global payment, like how do you handle the drug costs and not put risk on hospitals for the drug costs. So, you know, I haven't worked with CMMI directly, but it sounded to me when I read it that they solved that problem by excluding it from the global payment. So up and down, that will still be on the fee-for-service. So hospital is not assuming the risk of those high-cost drugs under the model.
Yep, got it. And then I think my other question is, it seems like should Vermont want to vary from the CMS model, that we would want and need to have data to support our proposal in terms of why we were asking for that. Is that fair assumption?
I think so. Again, I don't know how they're going to negotiate. There are requirements on what the methodology will include. We'll get to it. I haven't seen, you know, there is not a specific rule on the included excluded services, just saying that facility payments should be included at minimum. So I imagine as they are looking at the CMS, you know, approval process, that they would want to see why you are varied from the CMS.
Thanks.
All right. Any other questions? Time check 11:30. We continue until 12. Is that right?
Yeah, we have till 12. Yep.
Okay. All right. So let's go to the next slide. So that's included, excluded services. Decisions need to be made. Now let's go back to baseline adjustment. So this was discussed previously, so I'm hoping we can go quickly. So historical baseline is the weighted average of the last 3 years. Transformation incentives, CMS provided this as well, 1% additional funding to join in the first 2 years of the program. And we've been discussing how we can account for low utilization and low starting point for Vermont. So based on the negotiations, we created this additional adjustment for the Vermont methodology to fund Vermont delivery reform. The idea is that based on the negotiations, this funding will be used for targeted investment to support delivery transformation. Next slide, please. On the baseline historical revenue, there are weights used for the last 3 years. You see that in the table. 2022 gets only 10%, 23 gets 30, and the 2024 60%. For Vermont, we propose to use the same weights, but we add additional consideration for the 2024 revenue. And if the 2024 is higher than the weighted average, our starting point would be 2024. All these baseline trends will be adjusted for inflation and major changes happening. For example, the UVM's transition to sole community provider and increase in their rates would need to be factored into as we are averaging. So it's basically 2024 adjusted for inflation and policy changes and comparing weighted average versus 2024. The rationale for proposing this change is we believe if you do average and that average is lower than 2024, that in this I can't tell that world, that doesn't create incentive for hospital to join, because by joining in the first year, hospital revenue is going to be much less than 2024 as a starting point. So that's the rationale for looking at the two. Pennsylvania Rural Health Model did that. Maryland, when they set their initial budgets back in 2013, they also used a similar approach. Next slide, please. The baseline incentives, the CMS is providing 1%, so we included that in the Vermont methodology as well. The rules for the CMS methodology is it's available only for initial 2 years, and if hospital exits the model before PY 6, they would have to repay those funding to CMS. For Vermont, there will be additional considerations to create that funding pool. And if you go to the next slide, I just wanted to give you kind of where we are. And we did look at those numbers early in the slide, but looking at the actual or adjusted payments, the Vermont per beneficiary spending is about 10% lower than the national average. If you look at other rural counties, Vermont is still lower, 9.8%. So the idea is that through the CMS negotiation, there might be funding available to Vermont to fund the delivery reform. And there are a lot of decisions to be made regarding this concept. In addition to the actual, yep.
Do you have a sense? Sorry, do you have a sense of how much money that delta is? If Vermont is 4% less for an adjusted beneficiary health status and standard price as opposed to national, how much money is that? Just ballpark, if you have any sense.
I did have that, but sorry, I can't remember right now.
That's fine.
Yeah,
I can follow up with you later.
Yep. I'll add that to the slide deck and update the slide deck. How is that? Okay. Next slide, please. And as we are finishing the baseline comparisons for just to think about from all payer perspective, this table includes Medicaid and private insurance. And please note that the years of this table is different. So Medicare is 2021, Medicaid 2019, and the private insurance 2020. So on a per capita basis, in this example, without any adjustments, Vermont is showing 17% lower than the national average. On the Medicaid side, full benefit Medicaid enrollees, Medicaid expenses are 37% more than the national average. On the private insurance side, we see that 11% higher spend in Vermont. And overall, when you look at the total all payer, the Vermont spending is 25% higher than the national average. So we talked about this. You are not, you are not, this is not news, that on the Medicare side, we are lower, but on the all payer side, Vermont is much, much higher. So that's the dynamic to start with. In the next slide, there is a table showing all payer numbers by service lines. I'm just going to point out the hospital care, which is third down in the row. So Vermont hospital spend per capita is 48% higher than the United States national average. And you just see that there is a variation across others, but mostly they are much higher than the national average. So this is the all payer view. As we're thinking about Medicare, we are focusing on Medicare view.
The other one, Shule, just to interrupt, it's sort of aberrant here. It jumped out at me when I saw this is the prescription drugs and other medical non-durables for Vermont, 23% below national.
Yep.
Great.
One quick clarifying, it says on the chart 2020 and it says on the title 2019. I know it's a small difference, but I'm just, given COVID was 2020, I'm just curious which is right.
So great question. Details, the service line details are 2019. You see there are two health spending per capita numbers. 2020 is 25% higher. 2019, it was 26% higher. And all the detail below is 2019 because there's no available data right now for 2020.
Okay, thank you.
And then I just want to clarify this. I think when we look at these charts and we see hospital care, that's referring to all the services that hospital provides, both inpatient and outpatient, all the primary care services that are hospital based. Is that correct? Or is this just, I assume this isn't just inpatient care.
It is not inpatient care only. It includes hospital outpatient care as well. Let me just see if there's any information here. I need to get back to you whether it includes physician. I don't think it does, but I will go back and check what else is in there.
I think when I looked at this, the physician and clinical services is not included in the hospital care, but basically like the facility side of things.
Yes, I think you're right. All right, moving on to the next slide. So that's the baseline. On the annual updates, there are a series of adjustments that we need to consider in the methods. And we try to group them into annual payment updates and the performance updates. On the annual payment updates, there is an adjustment for inflation and additional adjustments for CMS Medicare policy. The purpose is to provide the similar updates to Medicare general trend. Whatever there will be some minor details, but in general, the idea is that they get the fee-for-service payment updates as a base on an annual basis. And there are some exceptions to it. On the utilization updates, to address some of the concerns around access and incentives to reduce utilization, we need to think about how to adjust the budgets appropriately to reduce that rationing concerns under global payment, and also provide additional funding to focus on population health services that the communities need. Social risk adjustment is a new adjustment, and this is coming from CMS methodology as well, to provide additional up to 2% funding for hospitals serving the most disadvantaged population in the community. And the critical access adjustment is one requirement that CMS is making is that the critical access hospitals will not reconcile back to cost report. but they are designing additional protections to minimize the risk for critical access hospitals. The way CMS has done it to create a reimbursement floor for the critical access hospitals using their latest cost report as a floor. So, and the purpose is to move them away from cost-based settlement and create financial stability at the same time. So those are 4 types of annual payment updates in the methodology, and almost all of them are required by CMS. I believe the state has a flexibility how to do it, but we need to speak to how we do these required adjustments in the methodology. Next slide, please. So if you dive into a little bit deeper on the inflation and policy, the Vermont methodology has a inflation adjustment using PPS market basket, and it doesn't include productivity adjustment that the fee-for-service methodology has for Medicare. And that usually is about 0.3 to 0.7% reduction in the market basket. The other policies will be similar to fee-for-service or COB reimbursement-based methodologies. The IME-DISH UCC, so those are the additional funding that the hospitals receive from CMS. It will be either similar to fee-for-service, or it could actually create more revenue because the methodology has this floor concept that they're not going to get anything lower than the baseline payments that they received. The floors for cause, the team is still working on how to adapt the floor idea for critical access hospitals. So that's the missing piece that we are working this week and next week to establish the Vermont version of the floor for critical access hospitals. The quality, all CMS quality programs will apply to the payments similar to the fee-for-service, and the other policies like sequestration will continue to apply to global payment as well.
Shirley, can you just explain the productivity adjustment a bit more?
So this is a standard adjustment that the CMS applies in their update factor when they do inflation. So market basket comes from goods and services provided by hospitals. So they track the inflation. And then they do have a productivity calculations using Department of Labor. So it's basically savings from the inflation that the hospitals, through the improvement in care, they expect productivity, right? So it's the same number for all hospitals. So they reduce the inflationary adjustment by this percent based on the result of that year as a kind of savings to the CMS through productivity. So expected efficiencies in a way, the way they put it. Next slide, please. So here is the hospital market basket projections. They are updated quarterly. We had this data from, I think, December. So there might be new numbers now, but in general, the forecast is about 3% inflationary adjustment starting in 2025. And as you see that the projections are showing the inflation is going to go down by a 1% over the years. I'm sorry, 0.1% over the years.
Shule,
Yep.
if you do slide adjustments, we're missing 23.
I will get that in. Thank you.
Thanks.
So that's the inflationary adjustment. On the utilization, we have 2 types of utilization adjustment. One is beneficiary changes. As Medicare enrollment is declining, the Medicare payment would decline accordingly. And the second one is service line changes. What happens if the hospital has opened a new service line or closed a service line? What type of adjustment would we need to make in the global payment? The purpose is to prevent stinting of care, so counterbalance that concern, but also maintain funding for fixed cost and incentivize hospitals to open new services. So those are the two types of utilization adjustments in the global payment methodology. The first one is the beneficiary changes. Next slide, please. There is a difference between the way the Vermont methodology calculates beneficiary change compared to the CMS methodology. So I'm going to slow down here because I think this is one of the important adjustments that we make. Essentially, what we are doing is to calculate the changes in the Medicare fee-for-service enrollment, adjusting it for age, gender, and ESRD, and calculating a number for a hospital, accounting for migration of patients from one HSA to the other. So this is not done at a state level, but it will be done at the hospital service area level, and it will account for migration to each hospital. We will be using the Medicare enrollment numbers, and as you see in the table, Vermont experienced declines in the Medicare membership in 2021, 2022. But looking at the early data from 2023, the changes in the membership count seem to be stabilized at 1.9% decline. You see the Advantage membership counts in this table as a reference, that the declines are a result of changes to Advantage, but also as a result of unfortunate events with the COVID as well. In 2023, 21% of all Medicare beneficiaries are Medicare Advantage. So at the end, as we're thinking about Medicare global payment, that pie is shrinking due to enrollment changes. The CMS methodology is using population growth as a starting point, not enrollment growth. And what they do is they look at 65 plus growth rates. And once they calculate the statewide average change, they distribute that to the hospitals. In mid-year, they have a correction factor. They look at the actual change in beneficiaries, and then they adjust that number prospectively. If you think about the trends in Vermont, CMS methodology is going to give positive trend prospectively because 65 plus is growing. When they do a mid-year adjustment, it's going to reduce the global budget. So that CMS methodology is going to create a big delta in the way the payments will be corrected moving forward. And because of that, I think Vermont methodology currently structured would mitigate that variance and create that stability for the global payments. Let me stop there and see if there are any questions about CMS versus Vermont. Okay. Next slide, please.
Can I ask one question on that? Actually,
yeah.
Go back. So if we use the CMS methodology, Medicare does the calculations and the state doesn't pay for it, right? But if we use a state methodology, then we have to hire a contractor to run this and figure out how much it costs. I mean, and then we would have to pay for, the state would have to pay for running that specific adjustment.
Yes, state designated methodology, the state will be calculating it and CMS would validate it. If you use CMS methodology, you would still need some funding to validate CMS calculations as well.
Okay.
And I'll just say, I don't know that you can really break that down to each adjustment per se, because I don't, like, I'm not sure if CMS would, if we chose to go with, let's say, the CMS methodology here, I don't think we know yet. Will they calculate it and give it to us? If they're doing that, will they do that on our time frame or their time frame? So So I'm not sure that, and I'm not sure then how that really gets translated into an administrative cost, even if they're calculating it, but it's not on our time frame, then, we may not have to calculate it. So I just would caution against getting too granular in the assumption around the cost.
Yeah, I think that will create additional risk. I don't know if they will do it by using some portions from CMS calculations will create additional risk in terms of validating and making sure the flow of the calculations kind of impact other things as appropriately. All right, next slide, please. So once we account for beneficiary changes, these are a couple ideas and methodologies from CMS, how they handle the service line changes. The first one is market shift adjustment. The purpose is to maintain competition between hospitals. So the adjustments are done only if there is an increase at one hospital and decline at the other hospital. So that way the total cost doesn't change, but the hospital is still incentivized to increase their market share. There is an algorithm developed in Maryland and adopted in Pennsylvania. And the CMS is going to apply a 50% payment to those services. So if the hospital increased their ED utilization by 100 patients, first, we will look at whether there is a decline of 100 patients at other hospitals. So that's the market shift. And once that's determined, the hospital is going to receive only 50% of the fee-for-service payments for those 100 patients.
Can I ask sorry for asking so many questions on this, but so what if it shifts out of hospitals? I think Maryland had some experience with that, right? So that care was shifting out of hospitals into non-hospital based practices. Do we have a market shift adjustment for the hospitals in those scenarios?
So Maryland does that on an ad hoc basis, monitoring trends and adjusting the budgets accordingly if it is shifted to other providers. In the CMS Ahead methodology, they have this last one called unplanned volume change adjustment. So basically after 5% variance, everything got adjusted. Right, so even there, they don't really care whether it's shifted or not. In the CMS methodology, they say if it declined by after taking account hospital to hospital and plan service line, the rest will be adjusted if you exceed 5% change.
And that's 5% of what?
All
Overall
of the baseline
utilization?
volumes. Yep.
Okay. So that wouldn't be service line specific.
I'm not sure, actually. The specs are not that detailed. I don't know if they are doing this at the service line level or at the hospital level.
Okay.
My colleagues may have better insight into it. So that's the market shift, hospital to hospital. The service line adjustments are
Sorry,
prospective.
Shule,
Yep.
can I interrupt?
Yep.
On market shift. So the theory behind the 50% is to kind of account for fixed versus variable cost. Is that right?
Yes. And 50% is what was used in Maryland adjustments. So any utilization adjustments plus or minus is done at 50%. For critical access hospitals, CMS methodology actually has 100%. So for them, they could keep 100% in their historical. So there's no reduction for critical access hospitals if they reduce or eliminate services and approved in the second one as a service line adjustment. And service line adjustments would need to tie back to the state health equity plan, and they need to be approved by the state and the CMS.
Ms. Garovich, I think we're going to have to stop there today, and it actually seems like a good spot since this is a area of deep complexity, and I think we'll need to spend quite a bit more time on it. We had a couple hard stops for noon today. So we'll be picking this back up on Wednesday. So, and we'll connect before then, but I think we'll probably start this slide and maybe even the last one and then kind of reconvene from there. I will really quickly see if there's any public comment on this. We are bringing it back up Wednesday, so if there's any public comment, let me know by the raise a hand function. Okay. Hearing none, is there any old business or new business to come before the board today? And is there a motion to adjourn?
So moved.
I think I
Second.
see did Sharon Goodwin have a public comment?
Didn't see her hand raised.
Sorry, no, I just didn't
Okay.
take a hand down, my mistake.
Right.
Thanks, guys. Great questioning. I'm very impressed with the discussion from all of you guys. Thank you.
Thank you. We appreciate that. Dave, did you plan that?
No, it just popped up that you had your hand up. So
I second the motion to adjourn. All those in favor, please say aye.
Aye.
I
Aye. We are adjourned and thank you, everyone. We'll see you on Wednesday.